So today I'm going to talk about the liver and biliary system, and I want to talk a little bit about the pancreatic system as well. And we're going to touch just briefly on sinus tracts and fistula, which is the end of Merrill's Atlas, chapter 15. So the liver is the single largest solid organ in the body. The area-wise, the lungs may cover more area, but they're not solid. The liver is solid, covers both the left and right upper quadrants, just kind of bridges in between them. It's divided a little towards the left-hand side by the falciform ligament, and that will give us our right lobe, which is really large, and the left lobe, which is in comparison much smaller. And then you've got minor lobes in addition to those. So we get blood to the liver from two different sources. One would be, it has to have arterial blood, so we have the hepatic artery, and that comes off the abdominal aorta, but we also get blood from the portal vein, and so that would be venous blood that the liver then has to process. Primary function for our standpoint is the production of bile. So bile is collected by the ducts and is carried to the gallbladder for storage and concentration. Once the bile gets into the gallbladder pulls water from it and it concentrates it. Then if you eat something that's fatty, then the purpose for the bile is to emulsify that fat. So you eat something fatty and your body will detect that, and cholecystokinin will cause the gallbladder to contract to squeeze some of that bile into the small intestine so you can emulsify that fat or digest that fat. So the pancreas, we're going to talk about the pancreas primarily because the ducting for the bile joins up with the ducting for the pancreas. So the head of the pancreas lies in the C loop of the duodenum. It's both an endocrine and an exocrine organ, meaning that it secretes into the gastrointestinal system, but also directly into the bloodstream. So into the bloodstream, we get regulation of blood sugar, and that's insulin that's released, and that insulin is created and stored in the islets of Langerhans inside the pancreas. But the pancreatic juices also get secreted with bile. So the biliary system consists of bile ducts and gallbladder. The two main hepatic ducts in the liver are left and right. So what you have are kind of like trees up in the liver. You've got the left lobe of the liver with its bile ducts, and you've got the right lobe of the liver with its bile ducts. So those come down to join together individually to create the left and the right hepatic ducts. Those two join together to create what we refer to as the common hepatic ducts. So they kind of join together like that. And then that joins together, that one big duct joins together with the duct that comes out of the gallbladder, and we refer to that as the cystic duct. And that gives us what we call the common bile duct. It's a duct that's common to all the secretion of bile from the left lobe and the right lobe, and also from the gallbladder as well. So in the biliary system, what we've got is common bile ducts joined together at the pancreatic duct with the pancreatic duct to create what we refer to as the duct of Wiersung. So that is your pancreatic duct. So if you're doing some sort of biliary system and exam and you see contrast go all the way up into the biliary tree and it goes all the way down into the small intestine, and you get that characteristic look of the small intestine in the duodenum, that's primarily what we'll want to see. But sometimes you'll get some retrograde retrograde filling of the duct of Wiersung or the pancreatic duct. Once in a while you'll see an anomaly, and that is that the patient may have a second duct in the pancreas, and that's what we refer to as the duct of Santorini. So that's going to come in one of two different ways. So the pancreatic duct and the common bile duct will join up together to create this expanded area, and that's what we refer to as the ampulla of Vader. And we're going to take a look at some diagrams here in a minute, and I'll point all this stuff out. So you've got the common bile duct, and then you've got the duct of Wiersung that join together to create this expanded area called the ampulla of Vader. But sometimes what you'll have, though, is you'll have a second pancreatic duct that parallels the first one. It might come off before the two join together, so it might come off here, or it might go into a separate sphincter or orifice in the small intestine. You just don't know. If it has its own sphincter into the duodenum, you might not see it on some of these exam types. So those two ducts, and they empty at what we refer to as they join together and they create what we refer to as the hepatopancreatic ampulla, or the ampulla of Vader. So the ampulla of Vader is the last portion of all that ducting before it opens into the small intestine inside of the duodenum, what we refer to as the sphincter of Oddi. So liver, the gallbladder right behind that, but you can kind of see the difference between the left and right lobe. This would be where the falciform ligament is joined. Now, the interesting thing about the falciform ligament is it's the fetal remnant of where you used to get nutrients from your mom when you were in the womb. So it's still, in most cases, still attached to the belly button, so to speak. So anterior view, posterior, inferior view. What we've got is left lobe, right lobe, the gallbladder back behind the liver, and then if you flip it over, that's what you're going to see. So what this does not show very well is that what you've got is not just the ducting, but you've also got arterial and venous blood flow that's going down the kind of encapsulated with and attached to, but separate from, this duct right here. This is what we refer to as the cystic duct. And just a couple of more views of it. So cystic duct, arterial and venous blood supply would be attached to that. So the reason I keep bringing that up is that if a patient gets a gallstone and it gets lodged in the neck or in the cystic duct, it can cause swelling. And if that swelling edema gets bad enough, then what we're going to wind up with is compromised blood flow. So with compromised blood flow, if we cut off blood supply to the gallbladder for too long, it will die. That's what we refer to as a hot gallbladder. So sometimes if a patient has emergency gallbladder surgery, that's because this thing is already pretty much dead and it's on its way to becoming gangrenous, maybe rupturing. And since the purpose for the bile is emulsification of fat, you don't want that leaking out into the patient's abdominal cavity, or it could cause some serious problems. So the function of the gallbladder is to store bile, concentration of the bile. The complications is, they put this in this particular slide as if that is a function of the gallbladder, and that is not. Cholelithiasis, or the presence of stones in the gallbladder, is, for our purposes, probably the most common pathology in the gallbladder. There are some other things. Porcelain gallbladder is a condition where the entire gallbladder kind of calcifies. And it's kind of cool to see on an x-ray, but it's pretty rare. So the most common problem that we're going to have with gallbladder are presence of stones. So again, cholecystokinin is what causes that contraction, so that the bile will come up out of the gallbladder, through the neck, into the cystic duct, down the cystic duct, into the common bile duct, into the ampulla of Vader. That's this area right here, and that's the sphincter of Oddi. So this is the C loop of the duodenum. What we have up here is the right and left hepatic ducts, and just above those it'll split, and it's just almost like the brachial tree in the lungs. They just go everywhere. And we'll see that here in a bit too. So not a whole lot else about the gallbladder. It's just a sac, and it's usually found on the visceral surface of the right lobe of the liver. It's in the position of it varies greatly with body habitus. So where we have a patient who's asthenic, it's going to be very close to the midline, and obliques to get the gallbladder away from the spine are going to be important if you ever have to do any kind of gallbladder study. And also, if you have a patient who's hypersthenic, it's going to be broad. It's going to be kind of high and broad. So it's going to be narrow, or it's going to be medial and low in asthenic patients. It's going to be high and wide in hypersthenic patients. So it looks like that. So we've got it way down here almost in the pelvic cavity in this asthenic patient. The larger the patient gets, the higher it goes and the more lateral it gets. So we already talked about that. So now we're going to talk about the exam types that we'll do for the biliary system. Sonography, being the most common, is out of the scope of this particular program and this recording, so we'll take a look at an image, but we're not going to talk much about sonography. Also, oral cholangiography is not something that's done very often anymore. I don't know of any doctor's office or hospital that does oral cholangiography, but I'm going to touch on it anyway and just kind of tell you what the limitations are for oral cholangiography and from a historical standpoint, why it is we don't do it all that much anymore. We're going to talk about percutaneous transhepatic cholangiography, operative cholangiography. If you're a staff technologist, probably the most common that you're going to do this is providing you have dedicated surgical techs. The most common that you would do as a staff technologist would be a T-tube cholangiogram. And you may or may not do a whole lot with endoscopic retrograde cholangiopancreatography. Sometimes we have specialized GI suites inside of a hospital where those are taken, where they perform those procedures. So sonography of the gallbladder is probably most common, is least invasive. Doesn't matter if the patient's prepped or not, and for the most part it does a pretty good job. Oral cholangiography used to be the go-to. So if a patient was suspected of having a gallstone, then we would do what we refer to as OCG. And what we had to do with these patients was to have the patient very well prepped, so they would have low residual meal, then we give them some sort of cathartic. And a cathartic, just so you know, is a laxative. It's just very good laxative. Most of your hospitals keep small bottles of magnesium citrate around, and it tastes nasty, but it gets the job done. And it also may come with cleansing enemas. So the last time I did a oral cholangiogram was in a hospital. I'm not real sure why they still did these in that particular hospital, because they had ultrasound, they had CT, they had all the different means of doing a cholangiogram, and they were still doing orals. So the radiologists were very, very picky, and if there was any feces left inside of the abdominal cavity, they would reject the exam, so the patient would have to go home and go back through the prep again. And the reason for that is because the gallbladder can be very difficult to see on these particular exams. So what we do is we have the patient, take these steps, and then they take several iodinated tablets, like 6 to 8 tablets the night before the exam, and the gallbladder takes that iodine in, and then when it removes the moisture from the bile, and it concentrates the iodine along with bile in the gallbladder. So if we have gallstones present, though, especially up in the neck where we've got some swelling, then what we're going to have a hard time doing is getting the iodine up into the gallbladder. And so if the iodine doesn't get into the gallbladder can't concentrate the iodine, you can't see it at all. So it's a difficult exam from that standpoint. It's difficult to get the body to cooperate if the patient has gallstones, and gallstones being the most common pathology in the gallbladder. If the bile can't get in, then the iodine can't get in. If the iodine can't get in, we can't visualize gallbladder. So it's tough. So If, though, we do get good filling, and we'll take a look at an image here in just a minute, then once we get the imaging done, and we may have to do some obliques to get the spine out of the way, especially if it's an asthenic patient, then the patient goes to the cafeteria and eats some sort of fatty meal, like eggs are a good fatty meal for the patient to eat. And then they come back and we do the exact same images that we did before, and we see how well the gallbladder contracted and see how well it emptied. So that's what an oral cholangiogram used to be. And you'll probably, I'm going to just go ahead and say you'll probably go through your entire career without ever seeing one. But that's what the gallbladder looks like as it's full of iodine. So you see the cystic duct here, and if this patient had a stone here, then what you might see, or if they had a stone distal from that, then what you may see is some swelling of that cystic duct and the ducting before it. And we'll take a look at that as well. So some terminology you need to be aware of. We're going to take a look at the terminology, and then we're going to look at words made from the terminology. So these are really root words. Chole just means relationship with bowel. Cholangio means bowel ducts. Choledocho refers to the common bowel duct. Anytime you see cyst or cysto, that's a bag or a sac. Like we'll do a cystogram in the urinary system, and that's an exam of the urinary bladder. Angio is arterial blood flow. Grammography is radiographic imaging of. Scope and scopy is observation using instruments. So it would seem like this is a scope that you would put up to your eye and go in and look around with, but really cameras are attached to the scopes now most of the time, and we'll be looking at things on a TV monitor. And then in all these exams that we're going to talk about, what we're looking for is patency of the ducts. Patency means open. So is the duct open, or do we have something that's obstructing it, like a stone or potentially even a tumor? So cholangiogram means radiographic examination of the bile ducts. Cholecystectomy is surgical removal of the gallbladder. And then a choledocoscope is that instrument that you would use to do a common bile duct exploration. So let's say the patient goes to surgery for a cholecystectomy. We know that they've got gallstones. I'll explain this a little bit deeper in a bit, but they'll clamp off the gallbladder. They'll make a cut into the common bile duct, or into the cystic duct rather, and inject some contrast. So that will be a cholangiogram. If there are some residual stones, then they may go in with the choledocoscope to try to extract those stones. So percutaneous transhepatic cholangiography is a special procedures or interventional exam where they take this long needle that they refer to as a Chiba needle, sometimes referred to as a skinny needle procedure because it's like an 8-inch long small gauge needle. So small gauge means that it's skinny. And what they'll do is they'll stick the patient through their external abdominal wall and until they can find one of the ducts, and then they'll inject directly into the duct. So again, what they're looking for is to try to find any kind of obstruction. What's preventing the bile from flowing either into the common bile duct or into the gallbladder, either one. So an operative cholangiogram is done in an OR suite, and it's done under anesthesia. And it's a removal. It's a cholangiogram done during the removal of gallbladder. So what we're usually looking for is gallstone. And what they do is they find the cystic duct, and they find it's kind of a capsulated duct type thing. And so what you've got is a cystic duct, then you've got the arterial and venous blood flow attached to it. So what they'll do is they'll grab it with these little grabbers, and most of the time it's going to be laparoscopically, meaning the patient has scopes inside of their abdomen. One usually goes through the belly button, and then they've got 2 or 3 others going into the patient's abdomen. So what they'll do is they'll try to separate the blood flow and clamp it off because they're going to remove the gallbladder. They want to stop the blood flow. So clamp it off, and then what they'll do is they'll put a clamp on the cystic duct close to the neck of the gallbladder. They'll make a small slit, and then they'll feed a catheter into the duct, and then they'll also staple that in place. So what they'll do then is inject contrast and watch as the contrast goes both up into the biliary tree and also all the way down into the small intestine. And what we're looking for there are filling defects. So the contrast shows up really bright, so it's a real white appearance. But if they've got a gallstone, the gallstone is radiolucent, meaning x-rays go through it very easily. So since it's radiolucent amongst all this radiopaque contrast, then what you'll see is it almost looks like a hole in the contrast. So there's only one of two things that are going to give it that dark appearance, and that is either there was a bubble in the syringe and the bubble got into the duct, or there's a stone. So if it's a bubble, you're going to see that bubble move, but if it's a stone, the stone's going to stay in the same place. So what our job is to, number one, if you ever find yourself in surgery, don't compromise the sterile field. So we want to maintain the integrity of the sterile field. We're going to have some heavy equipment we're going to bring in, be it a C-arm or a portable, either one. The C-arm, you may have to have some sort of drape on the C-arm. You may have to have some sort of drape on the portable. So we're going to move that into place. You can coordinate with a surgeon so that you don't expose the patient before the contrast is inside of the patient. So the surgeon may want to inject and step out of the room, and that's fine. The contrast is still going to be everywhere it should be. So they're going to inject. You're going to make your images, maybe with portable, maybe with a C-arm. And if you are shooting with portables so that you've got limited exposure, just one single shot, then you're going to have to also coordinate with whoever's running the anesthesia, the anesthetist, to turn off the ventilator so that the patient's not breathing during the exposure. If you're using portables, then most of the time what you're going to do is you're going to take two images. So you put the image receptor in there should be a little canal in between the base of the bed and the pad the patient lays on. So you put it in, you make your exposure, you pull it, well, in a digital world you wouldn't pull it out, you'd shoot it again just to make sure that any dark spots don't move. So if they do move, that's an indication, again, that it's an air bubble. If they don't move, then that's an indication the patient has a gallstone somewhere inside that duct. So if then they demonstrate that they've got stones still in place, then they might do a common bile duct exploration with a choledocoscope, and they might do a basket retrieval. So what a basket sounds kind of complicated, but really what it is they'll take this wire, it just looks like a solid wire, they'll put it inside of the patient, but it's not really a solid wire, it's got a plunger on the end of it, kind of like a needle. So they put this thing inside of the ducting and they push it past the stone. And when they push that plunger, what happens is you find out that that's not a solid wire, but it's a portion of it is three wires, and when they depress that plunger, they separate like that. And it's in the middle of this wire. So there's wire on either side of it. So what happens then is they push it past, and then they drag it back, and once they get to the stone has a tendency to get stuck inside of it, and they close the basket around it, and they can retrieve the stone. So that's the purpose for the common bile duct exploration. The choledocoscope is the means of getting that wire into the patient, that basket into the patient. If they've done all of that and the patient still has stones that they can't retrieve, then they may take a tube and put it inside of into the common bile duct cystic duct, whatever they have exposed and cut open. So what that tube looks like is it's a T-shape. So it comes up and it splits, and it has arms that go out in both directions. So the T-tube is put into the ducting and stapled in place so that the patient, the bowel has a place to go. All right. So if they've still got kidney stones and the bowel can't go down into the abdominal cavity, it's got to go have a place to go. It could be that so much pressure has been built up on that stone that we've got so much swelling that the stone can't move. So placing the T-tube into place gives the stones a place to go, the bowel a place to go. Some of that swelling can come down, and the stone may move either down into the small intestine or back out through the T-tube. So it relieves the pressure and reduces all that. So then what we may do is still in the operation, during the operation, we may inject the T-tube to make sure the T-tube is functioning the way it should. So that two things here. One is we're injecting through the T-tube, and if you remember back to our list, we've got a T-tube cholangiogram. That is not what I'm talking about here. T-tube cholangiogram is post-operative, and we're going to talk about that next. If you do any kind of cholangiography in surgery, that is operative cholangiogram, even if they are pushing through the T-tube. So post-operative T-tube cholangiograms are maybe 2-3 days after the patient had surgery. The patient comes down to the x-ray department, and we'll inject that T-tube again and look and see if the stones are gone, or if the contrast goes all the way down into the duodenum. So T-tube cholangiogram, that's operative cholangiogram, percutaneous, post-operative. There we go. So it's also called delayed cholangiography because it's done a few days after the surgery, and it's done in radiology through a T-shaped tube using diluted injectable contrast, so spinal contrast, ISOVU, Omnipaque, something like that is injectable. What we'll do is we'll dilute it in a lot of cases and inject it. If your hospital does not dilute it, that's fine. So what we're looking for is we're looking for patency of the ducts, see if the swelling has gone down, see if see what it looks like at the hepatopancreatic ampulla evader, see if the sphincter of Vodi, see if it releases contrast into the small intestine. And then also look for those filling defects that may indicate the patient still has a stone. So much like the oral cholangiogram, we need the patient to be as clean as possible before that. If we do this procedure and the patient doesn't have any kind of stones left and everything looks good, then the radiologist may elect to pull that T-tube on the spot and the patient can go home. So that's a T-tube, and if you look real closely, you can see why they call it a T-tube. You see the tubing come in like that, and then you've got branches that go into each direction here. So you can see down here, we can see the small intestine. So we've got drainage through the ampulla evader, through the sphincter of Vodi, and we're going all the way up into the biliary tree. You can see the patient's a little bit obliqued, which is common. And so most likely what they would do is pull that T-tube out. So the ERCP, again, is often done in the GI lab, and it's a procedure where we go in the opposite direction. So it's endoscopic, so it's going to be with a scope. Retrograde, meaning we're going to go against the flow. Cholangiopancreatography. So what we're going to do is we're going to put a scope all the way through the patient's stomach into their small intestine and cannulate the sphincter of Oddi and inject contrast. Now, sometimes what they'll do is they'll again use some sort of basket and try to pull stones through the sphincter of Oddi. What they might do is cut it just a little bit so that the stone has more room to come through. Think something like an episiotomy. It's kind of what's it's kind of a strange example, but it's kind of the same principle. They cut it just a little bit, the sphincter a little bit, so the stone can come out into the small intestine. So most of the time, again, we're looking for kidney stones, and it can be done pre or post-op after the patient's had their gallbladder removed. So they spray a local anesthetic into the patient's throat. They'll do what they refer to as IV conscious sedation. So they give them enough anesthetic that they're not completely asleep, but they're not completely awake either. Something similar to, I don't know, if you were having your wisdom teeth taken out, something like that. So that's what it looks like. This great big scope right here is the indication that that's what we're doing here. So that's your telltale sign of an ERCP. So you got the pancreatic duct here. If we had a duct of Wiersung, or I'm sorry, a duct of Santorini, it would come off maybe here and go up. But also, if they're doing the ERCP, they may actually see a second opening into the small intestine that would indicate that the patient has a duct of Wiersung, or duct of Santorini, rather, that goes all the way to the small intestine. Duct of Wiersung is the pancreatic duct. Accessory is the duct of Santorini. Sorry, I keep flipping that around. So fistula and sinus tracts are, we kind of confuse the two. Sometimes they require some sort of imaging, and that will be injection of iodinated contrast. So what we're going to need then is something with a balloon on it that we can put inside of the lumen or the hole of that fistula or sinus tract to keep it from spilling out before we're ready for it to. So we'll want to see where it goes. Is it a fistula or is it a sinus tract? Well, the difference between the two is a fistula connects two organ systems. So one that's, I won't say it's common, but it's an example would be where the urinary tract and the colon have a hole where they've come together and a hole between the two has formed. So what we would want to do is be able to assess exactly where the contrast is going. Is it just going to a sinus tract, which is just a blind passageway that ends, it's kind of like a dead end road, or is it truly a fistula? So we'll inject, we might use something like a Foley catheter. It's got a balloon on it, but it's flexible, it's small, it can get into tight spaces, not cause the patient a whole lot of discomfort, and yet at the same time we can inflate the end of it so that the catheter stays in place, but the contrast doesn't go where we don't want it to go before we want it to go there. So I hope that all makes sense. That's the end of this recording. So if you found this at all helpful or useful, please hit the like button, hit subscribe, and share with your friends. Thank you very much.